So next, Professor Jeppsson from Gothenburg, who's going to help us to identify the patient who will bleed, and then he's going to tell us how to prevent it. Professor Jeppsson, thank you.
Well, thank you very much, and thank you for the invitation to come here to the beautiful town of Edinburgh. I got this title from the organizers, and I'm trying to answer these questions during my talk. These are my disclosures. I think the most important one is the second one here. I'm a surgeon, not a coagulation expert, so please forgive me if I do say something wrong about that. First of all, bleeding is dangerous. It's actually sometimes life-threatening. And these are data from our own registry of patients operated in our clinic. We have a 4 times higher unadjusted mortality in patients that need re-exploration for bleeding compared to those not needing that. And you can see that this is maintained, this difference over time too. So bleeding is something that we should try to avoid. The first question on the title was, can we identify the patient who will bleed? And the simple answer is no. But what we can do is identify groups of patients with an increased bleeding risk. And the reason why it's difficult to identify these patients is, of course, that the perioperative bleeding is caused by a number of factors related to the patient, to the procedure, to the impaired hemostasis, so coagulopathy, the previous speaker talked about, but also, of course, the surgeon and his skills. And if we look at patient and procedure-related factors contributing to bleeding, there's been some attempts to use these as to identify patients with increased bleeding risk. This is the factors that have consistently been associated with increased bleeding: type of surgery, reoperation, acute surgery, low body mass index, and impaired renal function. And in 2011, the group from Papworth presented their Papworth bleeding risk score, where patients received different points, 0 points or 1 points, depending on 5 different factors: surgery priority, surgery type, aortic valve disease, body mass index, and age. So each patient could reach between 0 and 5 points. And then they divided the groups into a low risk group, a medium risk group, and a high risk group with 3 to 5 points. And they found, not surprisingly, that the patients with the highest points had a greatest risk of excessive bleeding. But you can see only 22% of the patients with a high risk actually bled. So it's difficult to use these data on an individual patient basis. This is also our material recently published when we look at independent predictors for bleeding more than 1 liter during the first 12 hours after surgery in almost 2,000 patients. And we confirmed in this study that BMI and acute surgery and CPB time were risk factors for bleeding. Going back to this schedule with the perioperative bleeding, if we take a look at the impaired hemostasis, it's even more difficult, because the impaired hemostasis, as pointed out by the previous speaker, is multifactorial. Preoperative medication, thrombogeneration capacity, low levels or intraoperative loss of coagulation factors, hemodilution, increased fibrinolysis, retransfusion, heparin, and so on. So it's quite clear that there's no quick fix for bleeding with so many factors that actually contribute to the bleeding. So take a little look at one of these factors, the coagulation factors, and more specifically, the role of fibrinogen. This is again our study where we could show that the fibrinogen concentration, the preoperative fibrinogen concentration, actually was independently associated to excessive postoperative bleeding, with a 28% risk for each gram per liter lower concentration. Fibrinogen is a complicated molecule. It has not yet been developed recombinant fibrinogen in large scale. The normal plasma concentration is 2 to 4 grams per liter. That differs a lot from the microgram levels of the other coagulation factors. And as late as 2006, it was claimed that 1 gram per liter was enough to ensure hemostasis. But I don't think that is true, especially not if you in patients with major surgery or patients with trauma. Fibrinogen is a key factor in the coagulation cascade. This is a simplified version, the surgeon's version of the coagulation cascade. where it's cleaved by thrombin to, and then it's fibrin, and this fibrin plug is then stabilized by platelets and factor 13. So the question is, does the endogenous fibrin concentration influence bleeding and transfusion requirements after cardiac surgery? And there's now quite a lot of evidence. This is not all studies, but most of the studies that had looked at the association between fibrin concentration and bleeding or transfusion requirements. And from the beginning, the studies were pretty small, but it's now much larger studies showing the same thing, that there is an association. This is a study which I referred to before, that we published this year. And when we look at the patients with low fibrinogen concentration compared to the one with higher fibrinogen concentration, it's quite clear that this is not randomly distributed. The patients with low fibrinogen levels are younger, there are less women, less patients with diabetes, better kidney function, higher hemoglobin levels, and less proportion undergoing CABG in this group. This is factors that you would expect, most of them, that they would bleed less than the patients with higher concentrations. But when we look at fibrinogen versus the postoperative bleeding in all these patients, there was a significant trend towards less bleeding in patients with higher levels and more bleeding in patients with lower levels of fibrinogen. Even more, the relation is even stronger when you look at the number of patients bleeding more than 1 liter in the first 12 hours, with a 3-fold increase in patients with endogenous level, preoperative levels below 2.5 compared to the patients with 4.6 or over. If we look at the CABG population, and I think this CABG population differs a bit because most of these patients are treated, or almost all these patients are treated with platelet inhibitors like aspirin before surgery. The associations are even stronger, with a 6-fold difference in number of patients bleeding more than 1 liter the first 12 hours in the group with low fibrinogen levels. Next question I want to discuss is the importance of preoperative medication, and especially antiplatelet therapy. Because this is again the study by Valdén, where we also showed that clopidogrel less than 5 days before surgery was associated with an increased risk for excessive bleeding, which have been shown in many studies before. But the problem today is that we do not just have clopidogrel, we have stronger platelet inhibitors today, both prasugrel and ticagrelor. And they differ from clopidogrel in a number of different, in a number of aspects, including the onset effect, the offset effect, and current recommendation says that we should withdraw ticagrelor at least 5 days before surgery and prasugrel 7 days before surgery. We have now 1.5 years, or almost 2 years of experience with ticagrelor in Western Sweden as the first choice in patients with acute coronary syndrome. So we analyzed all our ACS patients during an 18-month period treated with either aspirin and ticagrelor or aspirin and clopidogrel. And we had planned discontinuation of these drugs 5 days before surgery. But in reality, 30% of the patients had treatment less than 5 days before surgery, and 20% had until surgery, until the first day before surgery. And then we simply compared major bleeding, defined after the BART study, with bleeding more than 1.5 liter, reoperation for bleeding, or more than 10 units of red blood cells, and compare that with ticagrelor and clopidogrel treated patients. And what we found that there was no difference in major bleeding complication between patients treated with clopidogrel and ticagrelor. But the more interesting thing, this pattern differed quite a lot. If we withdraw it more than 5 days before surgery, there was no difference in bleeding complications. But if the patients were maintained on clopidogrel or ticagrelor until surgery, there was twice as many bleeding complications, major bleeding complications in patients treated with ticagrelor. And if we could discontinue it 2 to 4 days before surgery, we had more bleeding complications in patients treated with clopidogrel. And this is actually what you can expect from a drug which gives you more potent platelet inhibition but had a shorter offset time than clopidogrel. So let's go back to the title of the talk. Can we prevent excessive bleeding? I think we can prevent excessive bleeding. We need to optimize surgery, and with that, it's also the timing of the surgery. Can we wait 2 or 3 days, 4 days before we operate the patient? Should these patients be operated by experienced surgeons or a resident, and so on? The question of antifibrinolytics will be covered in the next talk. We give all our patients tranexamic acid before surgery. We need to monitor perioperative hemostasis in high-risk patients and in bleeding patients. We currently use the Rotem equipment and the multiplate. And we need to tailor the treatment, give the patient what he or she needs. When it comes to fibrinogen therapy, there's very few observational studies. The controlled trials are rare, and the randomized controlled trials are even more rare. But there have been a few attempts. This is a study from Fenger Eriksen in Denmark in 20 patients undergoing cystectomy. And they were randomized to fibrinogen concentrate or placebo if they have severe coagulopathy, as measured by the Rotem device. And they found that fibrinogen improved clot formation and reduced transfusion requirements. This is a study by Niels Reumeyer in Germany. This was one of his first studies, patients with thoracoabdominal aneurysms. It was non-randomized, and 6 of the patients received fibrinogen in high doses, and they found significantly lower transfusion rates and postoperative bleeding in the fibrinogen-treated patients. And this was his most recent study, where they did a randomized placebo-controlled trial in major aortic replacement surgery in 61 patients, and they found a huge difference in the number of allogenic blood products within the 24 hours, 2 versus 13, with less transfusions in the fibrinogen group, but they used a very high dose of fibrinogen concentrate. We did also an attempt. This was from one of our previous studies. We've found this relationship between preoperative fibrinogen concentration and postoperative bleeding. And we thought if we could move the patients from these lower concentrations up to a little bit higher concentrations. So this was a pilot trial, but we did it prospectively randomized, and the patients and the surgeons and the anesthetists were blinded in 20 CABG patients. And half of the group received infusion with 2 grams of fibrinogen immediately before surgery. The primary endpoint was safety. We did a CT scan to check that there were no graft occlusions in all patients. But we had also secondary endpoints, including bleeding, transfusion, hemoglobin levels, and some laboratory analysis. And what we found, that was no increased prevalence of clinical adverse events or graft occlusions. And we also find that the patients that received fibrinogen had less intraoperative bleeding, less postoperative bleeding, lower number of transfusion, and higher hemoglobin levels 24 hours after surgery. However, this is the only study on the subject, and I'm not advocating the use of prophylactic fibrinogen in patients undergoing cardiac surgery. I think this more shows the importance of fibrinogen in this setting. So we need to define the optimal time point for administration, the optimal dose regarding both safety and efficacy, to define cutoff levels, and to define the optimal combination of fibrinogen and other blood products and hemostatics with regard to safety and efficacy. So in conclusion, ladies and gentlemen, we can identify groups of patients with increased bleeding risks based on patient characteristics and biomarkers, but it's difficult to identify the individual patients. And excessive bleeding can be prevented or reduced by optimal timing, optimal surgery, hemostatic monitoring, and tailored treatment. Thank you.